hear me?
Yes, Dr. Chandra, you can go ahead.
Yeah. Sir, we are very much happy and pleased to have you here, sir, as a resource person today. And I'm very glad to introduce you to the group. And our resource person today, Dr. Kumar Venkatachalam, he is currently working as a medical hypnotherapy trainer at Universal Master Health Services. And he has been helping people to go through their past using whole person approach. And he has also been as a medical hypnosis and integrative plan manager at Master Health Hypnosis. And he has been a consultant hypnosis, and he was also an experience with psychosomatic medicines. So he's an alumni of Madras Medical College, and he did his Master of Science at Dakota State University, and he also has learned Ericksonian hypnosis in brief therapy at Milton Erickson Institute, Phoenix, the United States. Sir, we are very much happy to have you here, and thank you so much for accepting our request and being present. So without further ado, I hand over the session to you, sir.
Okay, thanks, Dr. Chandra, Dr. Suresh. I'm so glad, to be with you, to be with like-minded people, and it's a great service that you're offering. And all of these sessions being recorded and available for people to refer to in the future. That itself is a big contribution to the field. And I mean, apart from all the introduction, that probably came out of my LinkedIn, I guess. In brief, I've been here in the US for about 25 years now, 23, 24 years. And my career, in helping people, really started probably 30, 35 years back. So chronic pain has always been, of interest to me. And let me, tell you about a few events that happened in my life that made me kind of, think about this. I've been a hypnotist for maybe again, from 86, you calculate the time. That's the time, when I had my training in hypnosis. And around 88, what happened was, an uncle of mine, he went and bought a decorative sword. He went to Kashmir or somewhere in the north, and he got a sword. It's about 2 foot, 2 feet long. And at that time, I was with him, and there was no one in the house at the time, when I was, going to do what I was about to do, which was I took that sword and I was playing around with that. And, in my mind, it was almost like I was, a hero in one of these old, Tamil movies. So I was swinging the sword, and you know what? I just pierced myself in my thigh. It was not a very deep wound, but still, the sword went through, and had a lot of bleeding and everything. And so this was about 11 o'clock, 12 o'clock in the morning. So, and as I said, there was nobody, else in the house. So I had to walk to a nearby clinic. This was about a kilometer at least, or maybe more. And then the doctor said, he's going to, I'll need some stitches. I said, okay. And so he went ahead and, started preparing and all that. And he asked me, okay, so do you need any local anesthetic? I was thinking about this, and then because 86, I kind of, got interested in hypnosis. I said, maybe not, let's try without that. And so he started the procedure, and I ultimately took 4 or 5 stitches. But what I did was I imagined myself floating up and above from my body. So I kind of, saw myself floating above, and, I kind of, you can say it is an imagination. And then I can see the doctor, working on me. I see myself, floating up, and I see myself lying on the bed there also. And so it took like, maybe like say 5 minutes, 10 minutes, whatever time it took. But the whole time I was watching what was happening, but I was, floating about, let us say. And when he said like, okay, we are all done, I made myself go back. And I did not feel any pain. I didn't even flinch. And the doctor appreciated, hey, we did like, they put like, 4 or 5 stitches and you didn't even flinch, you didn't move. So this kind of, brought back to me the power of our mind and our imagination, especially over pain. So what is pain? How is that, you can say like, I had like 2 pains, right? Like, one was the pain, when I actually put the sword inside me, so like, when I pierced myself. So that is the first one. And then like the stitches. And even when I was playing around with that sword and, when I cut myself, I didn't feel a whole lot of pain. What I felt was guilt, shame, that, I was thinking myself as like this great hero and got cut in the process. So there was no pain per se, but it was more guilt and shame associated with it. And then fear, like, because I didn't know, like, to what extent, I had cut myself, did I go and like, touch a big artery or something? So all of these things were the ones that were going. And so pain was really like, in the background, it was not in the foreground. And again, like, so I went through these 2 different pain experiences that day. And again, pain was not the main problem. So this is one incident, always stayed in my mind. I knew personally that pain can be handled in a painless way, let us say. And then the second incident, I would say, was in 96, 95, something like that. When I was in Chennai, I was there like, to do a workshop. And then my parents were there, and by the time, like, I didn't think it must be 95. So I was in Coimbatore at the time, so I had come to Chennai, and I went and stayed with my parents, when I went for this workshop. So I finished the workshop, everything went well. I go back home, and there my mother was, her face was like swollen, very, a lot of pain. She used to get, migraine attacks. So she had like, this terrible pain. And she had taken medicines right from the morning, like maybe it started at 10 o'clock and I'm going there like maybe 6 o'clock, 7 o'clock. And she said like the pain had come just a little bit, but nothing, and she had tried all kinds of prescribed medicines, very strong painkillers. Nothing had worked. Or like had worked very minimally. And she was there like, with the swollen face and everything. So I said like, and because I had done, this workshop about 6 or 7 hypnotic sessions for people. So I said, okay, Mom, do you want to try? She said, yes, I'll go. So I had her, lie down, and probably took like 2 minutes for her, like, to go into hypnosis, even with all the pain and everything. And then I asked her, okay, can you imagine your pain as an object? Give a shape to that pain. Is that pain round or square or what? So she gave a shape and she gave a color, maybe red. And, initially she was, when I asked her to relax herself and all that, she imagined herself to be in a grassland, lying on the grass. And then I asked her, okay, so now can you bring that pain out and see it in front of you, like that square, red square, or, the red circle, whatever it is. So she was able to do that. And I said, okay, now can you make it move away from you slowly and take, your own time, like, but the thing is at the end, when this red circle goes far away and then disappears, your pain will also go away. So you take the time, you decide, how you want to do it. She took like maybe 2-3 minutes, and she said like, the circle had vanished. So now I ask her to come out of hypnosis, and so she re-alerted, and then she says the pain is gone. And this is a pain that had been there for like maybe close to what, like 6, 7 hours, 8 hours, and with all kinds of painkillers. And all I took was probably about 7 minutes totally. And this is a migraine pain. So again, what is pain? So it's if the pain, the migraine pain was caused by all of these nerves and then blood vessels and then dilation, whatever the cause is. So again, like that also posed a question to me. And then this is about a non-human. We had a pet, a brown dog, and this we usually keep him in house, but he also goes on the street, and he's like a king of the street. So goes around and then comes back. And one day he had an injury. He was hurt. I don't know how he got hurt. Like maybe got bitten, or like maybe something ran over or something. But one of his legs, he was limping. When he came, and he was limping for a couple of weeks or 3 weeks, 2 weeks, whatever time. And then this funny thing happened when normally because whenever I see him, and I am a very strict disciplinarian, and I don't allow him inside the house after a particular area. He can come within say 5 feet inside the house, but not beyond that area. So but other people are like a little bit casual about it, but I'm kind of strictly, because I thought he might bring in infection germs from outside, so not to allow him inside. And this dog, whenever he sees me, he would limp. But when he goes out, maybe he would limp a little bit, but whenever he sees another dog or something like that he has to run after, his limp would disappear. He would just run. So, but again, he comes back and he sees me, he would limp. So again, I mean, I can understand this in human beings. Sometimes we fake pain, right? People children get pain if they have a tough homework. They don't want to go to school. They play. Say oh, I cannot go to school with this stomachache. But a dog having pain like this. So what is this pain that happened for this dog? Is the pain is still there, but he forgets the pain when another dog comes, when he becomes aggressive, or when he becomes assertive, or he's playing a different role. His pain disappears. Is that what it is? Or there is no pain, but he is limping out of a habit, and then he kind of forgets the habit, because the desire to chase another dog is probably even more powerful than the habit that he is able to do this. Or he really doesn't have no pain, he doesn't really have no habit, but he is actually faking it, just because I mean, dogs can be manipulative, I know that, so they, maybe he's doing this because he wants to do this when I am looking at him. Or a fourth thing, maybe the pain had already gone, but even without his knowledge, whenever he sees me, I kind of look like a threat to him, in some ways. So because of that threat, this behavior, which he had learned, because that was his, pain behavior. When he had the pain, he had to save his leg. So that was already in the mind. And so whenever he sees me, even, it just gets triggered. And so he limps. So all of these are possibilities. So I was thinking all of these things. And all of these now have relevance when we discuss this phenomenon called pain. So let me share my presentation here. see how I do this presentation in share content. Screen one. Am I sharing now?
Yes, sir.
Okay, great. So yeah, probably I should have put up this one first. Anyway, so this is like so chronic pain and a mind-body perspective. So from like whatever we discussed till now, or whatever like stories I was telling you, to a certain extent you would understand this mind-body perspective and where I come from. So actually, this International Association of Study of Pain, that is that IASP, they kind of define pain as an unpleasant sensory and emotional experience. Let me put it on a slide show. Okay. Just a minute, give me here. Okay. So go to the next one. So this is an unpleasant okay. Now you can see the whole thing. So it is an unpleasant sensory and emotional experience. So they changed this definition. What originally the definition did not have this or resembling that associated with. The original definition was an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So this pain is associated with, it is not caused by. So if it is only caused by tissue damage, they would have said like, it is caused by an actual or potential, or actual tissue damage. So this is an experience that is only associated with, and it is unpleasant. It's an aversive experience, and we will come to like other kinds of aversive experiences. And it is a sensory experience. Obviously, there's like a sensation, and that sensation is recorded and reacted to. And then it is also an emotional experience. And there can be an actual tissue damage and a potential tissue damage. People get like afraid. Oh, what if I get this? But at the same time, it also defined as like resembling that associated with, and that is because, the story I told you about my dog, because the dog cannot say like what kind of an emotional experience he's going through, what his sensory experience is, but his behavior resembled that as if that is associated with some actual or potential tissue damage. So whether he had actual pain in the leg or like something that is akin to that or whatever it is, so it is something that is resembling a sensory and emotional experience of an unpleasant nature that he's going through. And so this word associated with again has an important meaning, because when I told the story of like how I went through this this process, like when the doctor stitched me up and I was not under any local anesthetic or anything like that. So what I did when I said, let me go and float up, that is the process of dissociation. And that is one of the natural ways that, human beings sometimes would react to pain. So when people suffer, with a lot of pain very suddenly, they faint. So what do they do? They kind of dissociate themselves from their experience. It is so much threatening, so much stress. They kind of separate out of their body self, and to a certain extent, that is what I did when I had to separate myself from my body and the pain that is associated with the body. So in a way, when pain is defined as an unpleasant sensory and emotional experience that is associated with this damage, now I am dissociating myself from that unpleasant sensory and emotional experience. So what happens, I'm able to now look at it, from a third party perspective, not as a person going through this process, a painful process, but I am kind of dissociated away from that. And when I said the story of my mother, when she had to go through this process of separating out, she was able to bring the pain out of her head and put it away and make it disappear. So, and I underlined the word tissue there because I think, a true pain or a painful experience doesn't even need the word tissue there. In my case, in my opinion, when we talk about a mind and a body, that is like an artificial separation. And we created that, our thinking, the past couple of millennia, I guess. They separated this mind and body so that we can deal with these phenomena in a better way. But it's the same. It is a system. We have a mind body, a whole person, a whole organism system. And then the system goes through processes to decide, hey, what do I do with this? I feel this stress. I feel this situation. How do I react to that? And that reaction can come or express through physical modalities, physical ways, or they can come through mental ways. If you want, again, I can separate it out. But there is usually not an experience that is purely physical or purely mental. When human beings spend most of the time thinking about things. And so that is why, so I would probably read this as an actual or potential damage to the person, or systemic damage. Because when I cut myself, again, I was not even worried about the cut itself. I was worried, here, hey, I'm staying in my uncle's house, and what happened here? Maybe because of this cut, when I'm bleeding, would I bleed onto their carpet? He has an expensive carpet. Am I bleeding on that? Or guilt. He had a decorative sword, and I had to take that and do this. So this is again an unpleasant experience, but it was not an unpleasant sensory experience. There was some unpleasantness, but the emotional experience was much more for me at that point than the sensory experience. I didn't care much about the pain at that point. So all of these, so just with this one sentence, you can kind of look at this in different ways, and that is how they defined it. Actually, if you read a paper on this, how they actually came up with this definition, they have a very good article on this, and it's a very great discussion. I would probably later on, after this webinar is over, I'll send you some references, through Dr. Suresh, and that may help you. Why is this thing not working? Okay. So this is a revised definition and the pain notes. They have an infographic like this that explains, why. So the first line, pain is always a personal experience. So you cannot say, hey, my pain is greater than his, or his is greater than me. So this, again, associated with biological, psychological, social factors. And pain and nociception are two different phenomena. What is meant by nociception? Nociception is the sensation that comes out of the actual receptors. We have like pain receptors in the body. Whatever comes out of that is nociception. So what they're saying is the pain and nociception are different phenomena. You don't confuse between pain and nociception. Nociception is the reaction of the receptors, whatever the response of the receptors to some stimulus. Here a painful stimulus, because nociception, it's a painful stimulus. So for any kind of a painful stimulus, how does the receptor react? That is nociception. Whereas pain is not that. So pain cannot be one-to-one. Oh, he has like a big cut, so it should hurt more, or he has a small cut. It is not like that. So throughout their life experience, individuals learn the concept of pain. So you might have seen, like, when kids run around, when they are young and one of them falls down, and the kid's mom, her mom comes and says, oh, see that? You can see other people are running. Go, get up and run after them. Okay, it is nothing. Or she might just say like, okay, oh, it is, or it's not too bad. It is fine. Can you run? And like, can you play with them? The kid would probably just run away. Whereas there's the other mom who comes and like this boy falls down. Oh, she then comes and like, oh, my dear boy, like you fell down, and oh, this is a great thing. You should not be playing. That's why I told you not to play with these kids. And so she makes a big thing out of this fall. So then the boy kind of, mom, all she says is like out of her own concern. But the message that the boy takes in is, okay, maybe falling down is bad. Maybe it makes my mom concerned. I should make sure that I am not falling down, or maybe I should not even play with the kids, so on and so forth. So these are all experiences that they learn even without the mom explicitly stating this, hey, you should not play, or something like that. So individuals learn the concept of pain. And a person's report of an experience as pain should be respected. We should not say like, he's just faking it. Pain is a personal experience. So only the person would know whether there is pain or not. So again, like, these things, go over the rest of the stuff, is like what we discussed anyway. So verbal description, again, is only one of the behaviors. And as I told you, in the story of the dog, that that pain is expressed in different ways, and in different emotional experiences also. And in this case of the dog, as a behavior, that verbal description alone is not representative of that. So this nociceptive pain, neuropathic pain, nociplastic pain. I'm just giving you some background in this so that we can again discuss this more. And mine, I would not say this is a very technical presentation. I'm going at it from my experience, clinical experience and personal experience point of view. So what do we need to understand to help with people with pain, and what are the good psychological approaches? What is that? Oh, I think like I heard an echo or something like that. Sorry. So this one gives you about like nociceptive. So when we talk about pain, so there are these pain receptors, in the body, right? And the pain receptors, once they are stimulated, they pass this pain impulse through fibers, nerve fibers, nervous system, basically. And then ultimately, like this pain signals, they reach the brain, and there's like a bunch of areas in the brain, and we'll see like a slide on that. Especially the thalamus is a very important region of the brain, and then there's an anterior cingulate cortex that's very important, and the limbic system is important, like amygdala and other things, and then hypothalamus, thalamus, and all of these are like important in different phases of pain, or like different features of pain. So the nociceptive pain is like where is an actual injury or hurt in the physical body where the pain receptors are stimulated. And it's like muscle or the skin, whatever is affected. So that is the nociceptive pain, where the pain is caused by an actual injury or a tissue damage. Whereas the neuropathic pain is like where the pain is caused in the nervous system, the nerve fiber itself. So that is the neuropathic pain. The nerves get affected by different things. The nerve can get cut. That people can suffer from diseases like, say, diabetes or other diseases. That can affect the nervous system, and then you get pain. And the nociplastic pain is like where there is no actual tissue damage, either in the receptors or in the nervous system, but still pain arises. So this is from altered system, nociplastic pain. And for the most part, what we are going to probably talk about is this nociplastic pain where there's no evidence of disease or lesion in the somatosensory system or in the peripheral receptors. That's like. So when we talk about pain, a lot of times we talk about pain in a very negative way, because pain, nobody says, hey, I enjoy pain very much. So we have to say that it's an aversive experience. It is an unpleasant experience. But at the same time, pain is absolutely essential. It's a very, very essential thing for human beings or for living beings for that matter, because pain signals you. Pain is a signal to protect you. There are two main things that protect us. One is pain, and probably the other is fear. So we want, we want to separate out the physical and the mental. Pain saves us from all physical damages, or tries to, and then fear protects us. Again, our body and mind, from going to dangerous places. So they prevent us from doing things, and we learn by pain. Once we touch fire, we don't go and touch it again. We know what fire does to you. So there are conditions where pain is absent. There's there are people who are born without the pain sensation. It's like congenital, analgesia. They have inherited some. They have absence of genes or changed genes that prevent pain from being felt. And you know what? They die very young. Even if they're eating food, they bite their tongue, they cannot feel it. So they constantly get injuries that they don't feel. They can go and sit on the heater and they don't feel pain. They can literally burnt by the heater without feeling any pain and die because of that. So pain it protects us, in so many ways. And you might have seen pictures of people with leprosy, advanced case of leprosy, where their fingers are almost gone. They lose body parts because they don't feel pain. So that even if you cut their finger, they don't realize that it is gone. And so pain is such a protector of us. So acute pain is like a specific event before which there was no pain. Something happened and I got pain. So that it is due to a direct tissue insult. And it is usually when I talk about there's a pain receptor, the pain, then the signal travels to the spinal cord, and from the spinal cord it goes to the brain, to the thalamus, and from the thalamus goes to the cortex and things like that. So all of it's almost like a telegraph transmission. So it goes from one place to another place to another place, and then so that is kind of the acute pain. Even there is a lot of I will have another slide there, because even acute pain, when I said I cut myself, that is an acute pain, but I did not feel that pain. And there are items that can modify even an acute pain. And the modifiers were one is my guilt and shame and embarrassment. All of that modified the pain. And then when I was the doctor, I dissociated myself. So that also modified the pain. So even acute pain can be modified. Chronic pain. In chronic pain, there are often no physical measurable changes. Usually something happens, somebody goes and has a fracture or something like that, or some kind of a damage, and usually the pain, acute pain, lasts for like some weeks, maybe like two months, maybe 3 months, 6 months. But anything that goes beyond that, then you say like, this person is now, the acute pain has become a chronic pain. And in chronic pain, a lot of times there are no physical measurable changes. Therefore, because you don't have a particular spot to treat, the whole person must be treated. So that is my perspective here. So that is what we call as the mind body. So when in chronic pain, because there's nothing specific to treat the person. There's this wonderful book called Relieving Pain, by Dr. Don Schaffer. He was a psychiatrist. He's no more. I think this book came out in 1993. And this is probably one of the best books I have read on pain. So if you have a chance, read that. And he deals with a lot of, very good material. Excuse me for a minute. So apart from this acute and chronic, we can also see about this chronic recurrent pains, migraine, where people don't have like, continual pain, but people get pain, once in a while. And again, like migraine, due to, hormonal factors, due to drugs, due to coffee, or like smells, if people go hungry, all of this. And again, IBS, irritable bowel syndrome. And a lot of people with irritable bowel syndrome, about 20, 30 years back, people got, used to be treated for chronic amoebiasis, and probably it is still like that, in India. I'm not sure. And I can say that with some, at least in a personal experience, my father had IBS. So I know, like, the behaviors of IBS people very intimately. And so this can be a chronic recurrent pain. It's a chronic situation, but the pain is not continuous. Pain comes and goes. Actually, Dr. Schaffer, he calls it as an acute recurrent pain, migraine pain. And by the way, this tension headache and migraine, all of that are part of what I would call in the forthcoming slide called as TMS, which is tension myoneural syndrome or myoneuritis syndrome, as it was originally called. People call it as TMS. So we'll come back to that. And when we talk about chronic pain, how are we doing with time? We're already 45 minutes here. Okay. So the spine findings, if you look at this is people without any pain. They just took, caught hold of a bunch of people and did, spine findings. So people now, like, in India especially, I see, and like in a lot of other places too, that people have like this disc prolapse, or the cervical spondylosis. Like, people go with this braces and things like that. And so this one, you can see there is like a disc generation, degeneration. It would say like if it is 40 years, 30 years, 50% of people have disc degeneration in 30 years. They don't have any symptoms, but the disc degeneration is there. So how do we generally say that this degeneration is the cause of all of these people having these back problems or neck problems that we see? And if you go to, like, so 50 people like 50 years old, 80% of their discs are degenerating. 60% have disc bulges. Close to 35 or 40% have disc protrusion. So all of these things. And so that is why it is not very easy to say, hey, like, your backache is because of your disc prolapse or disc degeneration. Most of the time, this low back pain is associated with other stress in life, and that is how they get into this. I mean, again, I'm not saying like all back pain is only because of how are we doing for time, Dr. Suresh? how many more minutes do we have?
Spent 45 minutes so far, sir.
Okay. And
So
it's
we might
almost
have,
close to,
so you might take 15 minutes more for the presentation and a little bit of discussion after that, sir. That
yeah,
if that
okay.
would help.
Yeah, that's fine. So I'm not going to go deeply into this gate control theory of pain or neuromatrix theory, and I will share these slides with you later. So let me escape from here. So again, like what is the neuromatrix theory of pain? Okay, so this is the gate control theory of pain. Again, we don't want to go there. Melzack actually is one of the names that you should probably remember for the purpose of, because he has done a whole lot of pain, and most of our pain discussion, especially with chronic pain, is based on his approach. So this is his, and it comes directly out of Melzack's article on this. So what he says is like, we have this body self neuromatrix. This body self neuromatrix is a concept, is a network of network in the brain. Let us say like it's a template, it is a die, it's a mold, about the whole body, in the brain. So, and it has like input. If you look at the inputs to the body self neuromatrix, there's like cognitive related brain areas, like the memories of past experience, attention, meaning, anxiety, all of those come into that, and the sensory systems and emotion related brain areas, all of that go into the neuromatrix, which then creates different outputs. So that is why like you cannot say like this area is affected and that is causing this pain. In pain there is no one-to-one correspondence between where the pain occurs and how we feel the pain. So the body self neuromatrix, which actually has an image of the whole body, in the mind or like in the brain, is what is producing our outputs. Where like it's a pain perception, and then it says, hey, move away from fire, or whatever, those action programs, and all the stress regulation programs, all of that. Let me just so on top of Melzack's pain neuromatrix, there is this thing called as the threat matrix. So where it looks at things that are happening and classifies them. Okay, this is a threat, this is not a threat, this is a threat, this is not a threat. And this is what actually hypersensitizes our brain. And the more the threat we face, and the more threats that we have faced in our when we were young, this adverse childhood experiences, all of that trigger this threat matrix. So then like from there on we say like, is this safe for me? So safety, not safe, or safety, safe or threat, safe or threat. This is how it goes. So when we address issues of chronic pain treatment, we should always address this issue of safety. We should make sure like the patient or the client is safe in his or her body, and that is that they don't have to classify things in terms of safety and threat. So these are all like chronic pain characteristics. And okay, one thing that I might want to show is probably in this slide when I later on save it with you. You see that like at the third bullet there, like which are called the defensive responses. So the defensive responses are like what comes out of this matrix. So it can be fear, it can be pain, it can be anxiety, it can be itch, it can be dyspnea, it can be nausea, it can be fatigue. All of this are to be considered on the same level of pain. So when I say like chronic pain, I should really say it as like chronic suffering. So the chronic suffering comes out of pain, fear, anxiety, itch, cold, nausea, dyspnea. All of the body comes out, or like our system comes out with any one of these. Pain is the most common, but all of these other things are also kind of considered equivalent of that. And then you can of course read through the protective items and all that. And I mean, there are like, so many, maybe, we need like a full day session for this anyway. So the brain process, how does the brain process? The way like I think about this is, and this is probably one of the most important points that you need to realize, which is brain works on analogies. These analogies are how like brain works on as if principle, or the similarity principle or pattern matching. So when I said like to my mom, hey, can you pull that pain out? So how do you pull a pain out? So she says like my pain is red color. So how does pain have a color? But for her experience, that is why like it comes out of a personal experience. For her, pain feels like red color, a red color circle. And now what happened is the brain took that, and when she was able to reduce the size of the pain, or like reduce the size of the circle, red circle, till it would become like a small dot and then like disappeared. The brain matched that for pain. Brain says, hey, like this is the pain. And when that dot disappears, the pain disappears. How can a red circle disappear and pain disappear at the same time? So brain works as if the red circle represents the pain, or as if the red circle is the pain. So I mean, these are all things that again, as I said, might need more time for me to discuss about this generalization, categorization, and how we actually so any chronic pain patient that you get, always find out what was the last time the person had pain and what happened just before that. For people with migraine, or whatever the case may be, get a snapshot. Who was there, what happened, where did it happen, when did it happen, why did, so on and so forth. So get the context, because again, chronic pain happens within a context. You have to find out the situation, where it happened, because it is not one-to-one. So you have to like learn all of these things, where these things happen, to give a particular context to it. So I was talking about this TMS and MBS, this mind-body syndrome, and PPD stands for psychophysical disorders. And TMS is tension myoneural syndrome that I gave. And he has written all these books. And this is the work of Dr. John Sarno, who was a professor of rehabilitation medicine. And he said, and he was the one who said, like, hey, if you have back pain, first be aware that the brain is the one that is causing your pain. It is not the body that is causing the pain. Mind causes the pain as a distraction to something else. Maybe the person has anxiety, stress, or whatever, but the mind deflects that, distracts that by producing pain in the body. And again, like this is probably one of the most important things. But I think, we don't. So these are all the 7 causes of how mind-body illness, or like in the pain in this case, come up. It could be a conflict. Most of the time it is due to conflict. You want to do something, but you are forced to do something else, because of societal issues, family issues. So when there is a conflict, the stress level increases. Stress, anxiety, and pain go together. And I usually call like, trauma along with that. So you would say like, I call it as the past. Putting your past troubles in the past is, the past troubles are pain, anxiety, stress, and trauma. So the conflict is like, and the way like, it comes out is like, through organ language. Somebody says, this job is a headache. They end up with headache. This job is a pain in the butt, so they, like where they would get the pain, so on and so forth. Okay, so all of these things are probably, I think, we are past the time for this. And this is like my background on understanding, pain and all that. Again, I will send this to you, and you can probably contact me later on by, email, or, maybe you can even set up some session, if you want to go through and discuss any of these things. My contact information is well, too many slides. So this my contact information there, and so you can reach out to me in one of these methods. This website is still coming up. Probably in a week it would be ready, and we can talk. So with that, thanking all of you, I am open for discussions.
So thank you so much. It was a wonderful, insightful, and informative presentation, I would say, sir. Thank you for your time.
Thank
And
you.
now I request the participants to interact with the resource person with your quick questions. You can unmute your mics or put your questions in the chat box. We can discuss. Thank you. Sir, there is not a proper question as such, sir, but one of the participants have put like they're experiencing the migraine pain for over 30 years.
Yeah,
I
I saw
think
that. Yeah.
So, do you have anything to say on that, sir? Like, how to connect it with our body and mind techniques so that we can ease that pain?
Actually, this migraine is also considered one of the TMS manifestations, the mind-body syndrome. So migraine definitely needs work, not at the migraine level, but what makes the migraine to happen. Usually, like, the migraine and headache people usually have anger issues. The anger, if they don't feel anger consciously, the anger is still there. So I would say, like, maybe journaling work, and first be aware, like, this migraine is not happening because of all the allergies. If she gets hormonal migraines because of hormonal changes, or like, because of any particular thing, most of these things are only triggers, but the actual problem is somewhere else. And that is what I put a picture of this alarm. So when the alarm goes off, the sounding part, like where the horn of the alarm, that is not where the problem is. The problem is in the sensor. So in this case, like, where we saw about this threat matrix and things like that, so that is what she has to look at, in terms of migraine. There are, like, instances that are happening around her that trigger this migraine because they trigger the threat matrix. So it's like so that is what is happening. So it is kind of, that is an cause and effect between the stressors and migraine. So she has to, like, I would suggest, there's this book called Unlearn Your Pain. And for the TMS, there's a place called TMS Wiki, and they have a 30-day program there, free program. So online, she goes, like, types TMS Wiki and take a free program that they offer. And that may be the way, like, she should start. In my case, I would probably help her with hypnosis. I can help her, like, maybe like 2 sessions, 3 sessions, or like somebody else, with the background. So that is my approach, where I kind of, see, like, what emotions are hooked to that.
Thank you very much, sir, for your reply. And the participants are requesting for your PowerPoint presentation so that will be useful to them. So you already said that you're going to share in the group. Thank you very much, sir. Yeah. So do we have any other questions or a quick feedback about today's session?
Dr. Chandra, may I?
With absolute pleasure, ma'am.
Thank you so much. Thank you, Dr. Kumar. It was a wonderful presentation, and you had so much to talk. And sorry, the time was not actually conducive. Thank you so much for the wonderful presentation. I have a quick question on it may be in reflection. So, any psychogenic symptoms of something related to disorders of mind-body related people who get an seizure. It is purely psychological, psychogenic nature. All this could be cured with hypnosis. Am I right?
I would say, like, hypnosis, but I would say, like, any good mind-body approach, I would say. Because, apart from hypnosis, early on in my medical career, I was practicing homeopathy, and I still, keep in touch with that and all that. And definitely there are, like, other mind-body approaches, that would be like homeopathy, it would be like acupuncture. I would say, like, mind-body or like whole body approaches, a lot of them can address all of this.
Fantastic. Thank you so much, sir. It was a wonderful listen. It was wonderful to listening to you, because this is the one area which people require a lot of insight. A lot of them are suffering because of pain, and whether it is an emotional pain or it is both an physical pain or manifested in physical pain. And I think this is the most wanted one. We would welcome you one more time on a detailed presentation also. From the core team, I request Chandra, can we go for, is there any question, or can we go for vote of thanks?
Ma'am, there isn't a question, so please proceed with vote of thanks, ma'am. But before that, I'll just give a line of my feedback to him. Sir, I like the line that you said about pain is a protector. So whenever I come up with pain, I'll remember the sentence and try to be more positive in dealing with it. Thank you so much for that line. And now I request Dr. Subhashri ma'am to continue with the word of thanks on behalf of all of us. Thank you once again.
So like maybe like, just one more sentence, before I, because based on like what you said,
Yes,
I
please.
said like, in the acute pain, I said like we dissociate from the pain, right? But truly dealing with chronic pain, you don't dissociate from it, you associate with it. That is one main difference between treating an acute pain and a chronic pain. Because in chronic pain, the pain is not just a protector, pain is a message. So you have to listen to the message. So in acute pain, you dissociate from the pain. In chronic pain, you go and associate with the pain. You go and sit with the pain and ask, hey, what is the message you are carrying to me? So that's like one last message that I have for you.
Thank you, sir. Thank you, sir. It is more wonderful than what I heard before. Thank you very much. And now it is our time to thank you, sir, on behalf of all of us. Ma'am, please proceed.
Thank you so much, Dr. Kumar. Is there anybody who would like to talk? Somebody is.
மேம் சார் குட் ஈவினிங் சார். நான் ஒரு கொஸ்டின் உங்ககிட்ட கேட்கலாம்னு நினைக்கிறேன் சார். தமிழ்ல கேட்குறேன் சார். நீங்க
ஓகே
இங்கிலீஷ்ல ரிப்ளை கொடுத்தா அண்டர்ஸ்டாண்ட் பண்ணிக்கலாம் சார். சார் இப்போ வந்து பெயின் பத்தி நீங்க நிறைய விஷயம் சொன்னீங்க சார். இப்போ வந்து ஒரு 2 years கிட்ட வந்து எனக்கு ரிமட்டாய்டு ஆர்த்ரைட்டிஸ். ஸோ அதுக்கு முன்னாடி வந்து நான் ஒரு டீனேஜ் வரைக்குமே, ஆஃப்டர் மேரேஜ் வரைக்குமே நான் ரொம்ப பேசிவா இருந்திருக்கேன். அதுக்கப்புறம் வந்து நம்ம டாக்டர் ஸ்ரீனிவாசன் சார் கிட்ட வந்து ஒரு ஆங்ஸைட்டிக்கு ட்ரீட்மெண்ட் வந்ததுக்கு அப்புறம் ரொம்பவே அசர்ட்டிவா கரெக்டா போயிட்டு இருந்தது. இப்போ அந்த 2 years இந்த பெயின்ல வந்து இப்ப ரீசன்ட் டேஸ்ல பார்த்தா ரொம்ப அக்ரெசிவா அந்த பெயின்னால துருதுருன்னு எல்லா வேலையும் பண்ண முடியாம யாரையாவது எல்லாத்துக்கும் கொஞ்சம் டிபெண்ட் பண்ணி இருக்கும் பட்சத்துல எனக்கு அது பிடிக்கல. ஸோ அந்த 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 டிபெண்டபிளா இருக்கிறோன்றத அக்செப்ட் பண்ணிக்க, அது ஏதோ ஒரு மாதிரி எனக்கு ஈகோ இல்லாத ஒரு பர்சன் வந்து இப்ப ஈகோ எனக்கு வருது. ஒரு மாதிரி ரொம்ப கோவமே வராது, உனக்கு கோவமே வராதான்னு கேட்டவங்க எல்லாம் இப்போ அப்படியே பயப்படுறாங்க என்னை பார்த்து. ரொம்ப அக்ரெசிவ் ஆகுறது, அந்த கில்ட் ஃபீலிங். நீங்க சொன்னீங்க இல்லையா, உங்களுக்கு காயமானப்போ உங்களுக்கு ஃபர்ஸ்ட் அது வலியோட கில்ட்டா ஃபீல் ஆச்சுன்னு. இப்ப இது வந்து இப்போ தூங்குற நேரம் தவிர மிச்ச நேரம் எல்லாமே அந்த கில்ட் ஃபீலிங். நமக்கு நம்ம யாரையா டிபெண்ட் பண்ணி இருக்கோம். நம்ம ஒண்ணு, எனக்கு வந்து ஒரு விஷயம்னா அது அழகா நேர்த்தியா இருக்கணும், அதோட அவுட்புட் அப்படி வரணும்ன்றதுதான் நான் பண்ற எல்லா விஷயத்துலயும் அப்படி இருக்கும். இப்ப அது வரல, யாரையாவது ஹெல்ப்புக்கு வச்சு ஏதாவது ஒண்ணு பண்ணப்போ அது எந்த அளவு வருமோ அவ்வளவுதான் வரும். அது வந்து என் மேலேயே எனக்கு அந்த கில்ட்டி ஃபீலிங், நம்ம நல்லா இருந்து நம்ம கரெக்டா பண்ணிப்போம்ல, கொஞ்சம் அழகா வர மாதிரி இருக்கு.
I can understand what you're saying. So this has changed you in some ways, right? Like from what you were.
சொல்லுங்க சார், நான் கேட்டுட்டு தான் இருக்கேன். சொல்லுங்க சார்.
So yeah, I mean, I understand that, and of course, again, like this can be helped. Even Dr. Srinivasan would be able to help you. And
இல்ல, ரீசன்ட் டேஸ் அதுவும் இந்த 1 weekனா வந்து ரொம்பவே ஒரு நெகட்டிவா, நம்ம எதுக்கு இருக்கணும், பட் யாரும் என்ன வந்து வீட்டுல இருக்கவங்க வந்து நம்மள ஒரு பேர்டனா நினைக்கல. அவங்க எனக்கு வந்து ஹெல்ப் தான் பண்றாங்க. ஈவன் எதுக்கு நம்ம வந்து அடுத்தவங்கன்னு ஏன் நினைக்கிறேன்னு எனக்கு புரியல. அதுவும் இந்த 1 week ஆனா நம்ம எதுக்கு இருக்கணும், வேண்டாம் நம்ம வந்து இருக்க வேண்டாம். அது வந்து ரொம்ப ஜாஸ்தியா நான் வந்து நிறைய பேருக்கு வந்து நல்லதா எப்படி இருக்கணும் அப்படிலாம் சொல்லியிருக்கேன். ஆப்டிமிசம் கிளாஸ்லாம் அட்டென்ட் பண்ணிட்டு அந்த அளவுக்கு எல்லாருக்கும். பட் இந்த 1 மந்த்ல என்னோட நிறைய சேஞ்சஸ். இந்த பெயின் வந்து டோட்டலா அந்த பாசிட்டிவ் தாட்ஸ் எல்லாம் தூக்கி போட்டு எல்லாத்துலயும் நெகட்டிவ். எதை பார்த்தாலும் அந்த நெகட்டிவ் தாட்ஸ்.
I think you probably have probably depression and things like that. I think I can understand what is happening, but probably we need to sit together and discuss this in detail. So maybe we don't have time, but I would suggest again going back to Dr. Srinivasan and continuing with it. Asking about this.
Thank you. Thank you.
Thank you, Dr. Kumar. It was a wonderful presentation. Please accept our gratitude from the core team. Dr. Suresh is our team lead, and we all have been working for the past 1 year on this mental health webinar series, and I think it's a very most relevant topic.
இந்த ஆன்லைன்ல எல்லாம் நான் கிளாஸ் எடுக்கிறேன், அது பண்றேன், இது பண்றேன்னு சொல்லி அத்தனை பேர்
May I request the audience to keep the mic little mute for a while. Am I audible, Chandra?
Yeah, ma'am. I have done. I have muted it. Please proceed, ma'am.
Thank you. So thanks a lot, Dr. Kumar, for the wonderful presentation, and it's a most needed topic also. I really love the way you connected the concept of how the pain is related to the mind, body, and soul, and I really like the way you dealt it, though we didn't have the time to actually listen to you totally. And please accept our gratitude from the Department of Psychology. Yeah.
Sure.
Thank you so much from the Department of Psychology, American College, and the associates like Madras School of Social Work and MS Chellamuthu Rehabilitation Center, Red Pond and Yellow Pond, and as well as the other associates. And our core team especially is very grateful for you. And I request from the core team that we must have one more session on pain management, especially through exercises, through practices, or some mind body practices could be like an intervention. It could be done.
Yeah, I had one ready for you, like a session, like a small one, but we didn't have time. But anyway, thanks a lot for hosting this and for doing and coordinating all of these things. And it's been I've gone through some of your videos and the YouTube items, and I appreciate all that you are doing and bringing in awareness among people on all of these subjects.
Thank you, Dr. Kumar. So kind of you. And I wish participants actually you can write your doubts, and if you have anything, you can actually be in contact with Dr. Kumar through the mail ID he has given, and you can ask him your personal doubts, because it's a very limited time for us.
Okay. Yeah, you're welcome.
Thank you. Over to you, Chandra.
Thanks.
Thank you very much, ma'am, for your kind words to Dr. Kumar, sir. And thank you one and all for being present this evening and making this journey more colorful and bright. So see you all tomorrow in another session, the same time, same link. Until then, signing off, saying good night and bye-bye.
Yeah, thanks.